Thank you, Thomas, and see everybody in another few minutes. So a good evening and good afternoon and good morning, depending on where you're logged in, and welcome back to the continuation of our seminar on orthognathic surgery. I am Dr. Kahugu, the moderator of this session, joined with Professor Sabine, Girod, and Mohammed Abdelazim as my co-moderators. So far, we've had the two talks, two presentations and case discussions on treatment planning, and the next one was on maxillary osteotomies, and now we'll have one on mandibular osteotomies. I would like first, on behalf of all the speakers and the moderators, to thank the audience for the very good comments and questions that you've been putting in the chat channel. I'd encourage you to keep on doing the same, keep on bringing up the points and the questions and having the discussion on the chat, and anything that is noted by the chat moderators will be brought up. In case anything is not brought up, do not worry. At the end, we will have a session, if time allows, for even more questions. It now gives me great honor to invite our third speaker of this session, and this is Professor Adnan Aslam from Pakistan, who's going to be talking to us about mandibular osteotomies. I'd like to welcome you, Adnan, and please proceed with your presentation.
Thank you, Eric. And a special thanks to Emily and Thomas for holding on the participants so far, and also to Sabine and Muhammad and Eric for moderating the session so far so well. So this is about mandibular osteotomies, and we are going to talk a little about the other osteotomies on the mandible also. This is majorly going to be about the most popular osteotomy on the mandible, which is the split osteotomy. So the learning outcomes would be that we would be wanting to discuss the various types of mandibular osteotomies. What are the different mandibular osteotomies that we can do for different kinds of mandibular movements? Basically discuss in more detail the surgical steps for the BSSO, the sagittal split ramus osteotomy, and then briefly discuss the complications of sagittal split osteotomy. When you talk about the mandibular osteotomies, Hurleyhan Rady was the first American surgeon who came up with the idea that the mandible could be moved into another three-dimensionally correct position by doing something, and this was the anterior subapical osteotomy that he talked about. And then Angle, when he started talking about the malocclusion and everything, he paired with the Blair, which was the craniomaxillofacial plastic surgeon of that time. And they started doing something, and Angle obviously knew that anything beyond the scope of braces or simple orthodontics would benefit from a surgical repositioning of the jaws. The more proper ramus osteotomy on the mandible was basically put forth by Vossmund, and this was the earlier part of the 20th century. I came up with inverted L osteotomy, which was more or less the same L osteotomy which is now used. And then eventually, Obergieser, after being tutored by Trauner and had his inspiration from Perthes and Schlossmann and Schuchart, invented properly and wrote about the procedure, which has now become possibly the most intricate bony procedure that you can do transorally on the mandible, which is the sagittal split osteotomy. So Hugo Obergieser not only did a few procedures, but then taught a generation of surgeons who then carried on the sagittal split osteotomy to the rest of the world. So when we talk about the mandibular osteotomies, there are procedures that you can do on the body. There are procedures that you can do on the ramus. And then obviously these are the one-time orthognathic procedures, but if you have to do put a distractor, you also would need to do an osteotomy, which you can do on the body or the ramus, or make this into an L-shaped osteotomy on the ramus, and we'll talk about that briefly too in a little while. So obviously ramus procedures are more popular because they move the whole occlusal table to the desired position wherever you have to. And basically segmental osteotomies, like in the maxilla, have not become very popular in the mandible because most of the times the occlusal plane is corrected with orthodontics, and then you can basically reposition the whole occlusal table to the right position. Now, the history of orthognathic surgery on the mandible started with osteotomies on the body. But then people start to lose interest, and they were done as late as the 70s. But this was basically done because there was no collaboration between the orthodontists and the surgeons. So they would possibly remove many a times first premolars and set back the mandible or set back the maxilla. And then obviously there's a caveat to doing body osteotomy, that you might end up damaging the periodontal tissue or damaging one of the teeth in between the osteotomy cuts. And obviously there was the nerve saving was more unpredictable in case of a body osteotomy. So just a couple of examples of a patient who is a typical low angle class 2 mandible here. As you can see here, let me change the pointer, please. Okay, it looks better now. So there's a typical chin camouflage. And so ideally, you need to let the occlusal plane be where, and then you do a mandibular advancement. Generally, is very stable and a single jaw procedure. But the patient was getting married in a month's time, and this is many years ago. We wouldn't do it again, but this was basically a case of anterior subapical osteotomy, in which only the dentoalveolar part of the anterior mandible was taken forward, and you can see that there's quite a nice quick result after that. Or similarly, another procedure that was taught to us by our mentor, Dr. Adnan, and this was basically combining both anterior subapical osteotomy and a genioplasty into one, and that he would call anterior mandibuloplasty. So we did this in, again, another case in which orthodontics wasn't an option and we had to do something. So we ended up doing basically a combination of both to both set back the mandible and also correct the mandibular deviation. So we obviously removed the first premolar on the left side and then took the whole anterior part towards the left side and then did a bit of chin correction both in the vertical plane and in the transverse plane. Now, when we talk about the mandibular setback, obviously body osteotomies are no longer popular. The two main contenders to do anything like a setback on the mandible would be a sagittal split osteotomy or a VRO. So sagittal split osteotomy is by far more popular. It's done transorally, so there's no scar on the face, and is more stable vertically.